Hello. I loved your speech. It's lovely. I agree in your principle on a lot of what you had said. We do need to make changes. In my opinion, our system is doing adequate. I've been in the insurance industry for 17 years, and I'm a young individual. So I'm looking at this as far as a lot of things I like to see fixed is to make sure us younger people don't start paying for the mistakes of our past or decisions that should have been made. I do agree that there are changes to be made. I've been dealing with individual and group insurance for 17 years. So that, I totally agree with you in that principle. Some of your things that I wanted to ask you was, when we talk about the $740 million uninsured, we all know that a lot of those people who are insured don't want insurance or don't want to pay for insurance, but they get included in this big number that gets thrown around a lot. You know, when we look at Medicaid is almost 40% of the state budget, my question is, we're all talking about how to fix, but no one ever asks how we pay for it. And the way I'm looking at how we pay for it is that you're going to be looking at everyone who's currently working. Medicare people don't work. Most of them don't. So what my question is where are we going to come up with the money to come up with all these wonderful ideas?
Well, you know, part of that is that sense we've created in the American public that we simply can't afford it. I have been in healthcare for over 40 years. My passion has always been the care of the poor. I got a master's in healthcare finance, so I could focus on not saying what we couldn't do for them, but what we could do for them. But I will tell you, it is much easier for me to get an appointment with a gastroenterologist at 3 o'clock on Wednesday afternoon for a poor person who's got an early sign of rectal bleeding than it is for me to get a gastroenterologist to come into the emergency room at 3 a.m. in the morning when they're massively bleeding, and that physician has already been dragged into my ER 3 times this week for patients he's not going to get paid for, and he's got a huge overhead. And you take that out to every other single condition. It is much easier to pay for good prenatal care than neonatal intensive care. It is much easier to pay for good diabetic education and nutrition education than amputation and an artificial limb and PT and all that. You can make that case in 1,000 different conditions. We need to look at how we treat people. Now, you can get paid much more for dialyzing the patient than preventing the need for dialysis. We need to focus on making our system driving to health and rewarding people who drive to health. We can't afford, and your generation and every other generation are going to pay through the nose if we keep on this road.
A couple of years ago, Michael Porter, an economist at Harvard University, spoke in a different forum here in this city. And he said that one of the problems with the medical care system was that everybody was trying to eat everybody else's lunch. Everybody was trying to pass the buck from the insurance company to the hospital, to the doctors, to the nurses. And rather than putting the emphasis on effective delivery of health care services. Would you care to comment on that?
I think that's true because we're all struggling. You look at the efforts for people to stay open when they've got huge charity care and huge bad debt amounts. So the hospitals have to struggle mightily to be able to stay open, and not only to be able to stay open, but to be able to pay their staff justly and appropriately, to spend the time with new equipment, to spend the time in orientation, so we don't have the mistakes we have. So they're struggling mightily. So to some extent, they may be looking like, and there may be a reality of, well, I'm trying to get more from the insurance company, or more from the copay, or more from Medicare, or whatever. Physicians have a terrible time. It is much more difficult today to expect a physician to do a huge percent of charity care than it was 30 years ago. Quite frankly, it costs physicians a fortune to open their office. Most of them come out with several $100,000 worth of medical debt. every minute. The level of complexity that they have to have in their business office to bill effectively with the multiple different plans they have to cope with is overwhelming. And so it is obvious that we've got this pie and everybody is trying to stay afloat with it. And if we looked at how that pie ought to be allocated, I think we could do a much better job.
One of the issues that you mentioned is the lack of preventative care due to high deductibles. Several insurance carriers, including Aetna, offer their high deductible plans with the preventative covered up to a point. How do you suggest getting the awareness out of these benefits to the masses, including employer-based plans and individual plans for people? Are you working on some kind of education piece that will help?
All of our member facilities have lots of health education programs. Many of them have wellness programs. They do health fairs, community education. It's a never-ending struggle. Sometimes people who have high deductibles don't read and don't recognize, and I know many insurance companies are doing good work at trying to have them look at a better way to get mammograms, colonoscopies, those kinds of tests. But quite frankly, many people, if you've got a high deductible and you think you've got a deductible for most things, don't realize that there are a certain group of things that you can get. And so it's a constant education, but frankly, that's still piecemealing it. If we had a better system where everybody knew what they had, it would be much easier for people. In many countries, people know what they have. They know they can go for this, or this. Whereas you have to say, well, what's my plan cover? I have to say, what does my plan cover? And so I would tell you that it will be a constant challenge to get that word out and have people believe it. Or do people believe they're eating up their total coverage for their insurance if they use that? So I think it points to how complex our system is, and the more complex you make it, the more challenges you have to get people to use it effectively.
Sister, I gather from your comments that you feel that it is advisable to decouple medical care entirely from the employer. In other words, is that perception correct, that just leave the employer out of it and leave it up to the individuals through whatever aid they can muster to get the medical care? And secondly, would you give your comments on single-payer, government-paid medical care vis-a-vis the current provider choice programs?
Sure. Actually, I'm not necessarily a proponent that in order to get good health care reform in the delivery system, that we have to decouple it from the employer. We have to get more consensus across it. And we can't have certain employers carrying the burden in a community and other employers not carrying that, not giving anything for health care. So I think we have to get more consistency if we keep it as part of our employer-based. And part of why I talk about getting a better plan and one that's compatible with our culture is, for many people in this country, they like it being part of their health, of their employment. And so we're not opposed to it. I mean, I think it could work not coupled, and I think it could work coupled. But if it is going to be coupled with employers, there's got to be a level playing field. You cannot have one group of employers paying for health care and then inheriting the burden of the costs that get transferred from other employers' employees when they're sick and they don't have any insurance.